right, welcome everyone. This is our Penn Medicine Princeton Health Behavioral Medicine Didactic series. And today we are working on our third in a series of 3 talks focused on eating disorders and substance use disorders. We do have CEUs available for this talk for folks that could use the EEDS system, the EAD system. And the code is 61TUNS. So I'll write that in the chat. And can let folks know at the end as well. Would love for you to get some credit for being part of this educational opportunity. And I will introduce our talk today and get us started. So Sarah Carstens, our Director of Substance Use Disorder Services, and myself, the Director of the Eating Disorder Program, have been brainstorming together ways to think about, where are there overlapping principles between eating disorders and substance use disorders, and where are there differences? And we sort of came up with this talk idea together about thinking about a Venn diagram as like a way to imagine differences and similarities between eating disorders and substance use disorders. And so this talk was really inspired by our conversations about, what's similar, what's different, and also how does that impact our approach for treatment for each of these conditions. And so I'm going to dive us right in to our topic today and, have us think together about intuitive overlaps between foods and drugs, right? So there's ways that people talk about this colloquially. We can see Cookie Monster is really struggling with his cookie dough problem. And that, brings us to the question of, substances can have overlapping chemical and biological properties, but it's unclear how substances are related to these conditions, these syndromes that we see in treatment, so eating disorders and substance use disorders. And just because both of these conditions involve substances doesn't mean that they're exactly similar. And I sort of think about ways to bring it back to the basics, right? So starting with the substances. And when we think about food and drugs, brings us to the question of what really is a drug. So I'd like to define that for us together. Drugs are substances, whether they're natural or artificial, that alter the structure or function of a living organism. Psychoactive drugs are the ones that influence our mind, right? Our brain, thoughts, emotions, and behaviors. And it's rewarding drugs that have addictive potential, right? And so really reward is something that underlies both food and other kinds of substances, which then, raises the question of how do drugs work? And if we had our great talk from Sarah last week about many different substances, but if we look at a summary here with all of our different drug classes, and their neurotransmitter mediators and mechanisms of action, you can see that all of them include dopamine at the very end, right? So dopamine is a core part of the psychoactive process of substances that can be abused. And dopamine is really heavily present in our reward system, which brings us to the question of what is a reward, right? So it's something that feels good, something that you would approach, and something that reinforces behavior. So it increases the likelihood of you doing it again. And this is really present, like I said, in that mesocortical limbic system and mediated through the role of dopamine. And I'll articulate what the role of dopamine is, in part because it's something that we can track in both substance use disorders and eating disorders. And so rewards can be natural or primary rewards, something the brain already thinks of as positive, something like food, for instance, which is what this system was really built for. And a secondary reward is something that you learn to interpret as positive. So that could be something like money or achievement can be secondary. And the way that rewards and dopamine sort of interact is that dopamine codes for the salience or the magnitude of the reward. It sort of predicts that something is going to be coming. And so a fun fact is that banana trees have this purple thing that is called the banana heart, which I think is just cute. But if a monkey sees this thing, it knows that there are bananas somewhere, right? So it's predicting a banana reward. And so if a monkey sees that banana heart, or in experimental designs, like a red flashing light, then it knows that the reward is going to come. And this is single unit recording of dopamine neurons. So you can see that dopamine is like, oh my gosh, bananas are going to be here soon. And then the receipt of the reward is less activity. Dopamine is coding for that's going to be really awesome in the brain. And in the brain, where this happens is in this mesocortical limbic pathway, which includes reciprocal interactions with the prefrontal cortex that can increase and also decrease reward value. So this mesocortical limbic pathway includes the ventral tegmental area, the ventral striatum, and that mid part of the brain, the amygdala, as well as the prefrontal cortex and hippocampus involved in memory making. And there are D2 receptors all the way through that pathway. D2 receptor density is one of our best indicators of some things that are related to addiction. So, for example, vulnerability to become someone with a substance use disorder. When people have low receptor density when they're younger, they can be vulnerable to becoming addicted to substances. And it can also be an indicator of tolerance. So people can start out with more receptors and have less receptor density through time as they have more exposure to substances or rewards. So this is really, the system in which we see most robustly the biological components to addiction, which is really important to understanding how these syndromes occur. And, of note, right, this is a natural system that also responds to food reward, and so could be implicated as well in how we conceptualize eating disorders. When we think about reward and reinforcement, I'll see if this video works for us, and if not, I'll just talk about it. Is it gonna work? Maybe. Is it working? Okay. Yeah, so this is the recordings that the rats do, right? So it has the single unit recording on its brain and it's learning how to play a task, right? And so every time it hits the right button, it gets like a little shock of dopamine. And that's also true for substances. Like we could set up a learning system like that with cocaine or with M&Ms, and the rats would learn really fast, right? So it's a biological system that is not just for humans, also goes all the way down to animals. And the way these rats really learn it very quickly, right? They're really fast. And to have that direct hit, that electrode to the striatum, it'll forego like water, cocaine, food, and it'll do it forever and ever and ever, right? So that is like really the motivating process of our behavior. When we think about how drugs become addictive, that's the same system that's involved, right? And so drugs impact this mesocortical limbic system with connections across the brain. And in the short term, it causes changes in the striatal gene networks and causes signaling differences in the receptors that are impacted by the drugs, which then leads to longer term adaptations. And so what those green squiggles are showing is a reduction in receptor density over time. And that reduction in receptor density then leads to persistent or compulsive or addictive behavior. So this is a process that gets learned through time, right? So just like the rat with the electrode in its brain, it learns really fast, but people do too. And over a period of time, our brain adapts and changes when it's exposed to different kinds of substances. And so there's a real role for reinforcement learning and a balance between reward and control systems. And so if you see in this initial part up here, there's roles for the prefrontal cortex in trying to, attenuate the reward reactivity, and that over time becomes less and less powerful. So if we think about how drugs become addictive, like I said, it develops in stages, starts perhaps with experimental drug use. And so if we use our monkey as an example, he might get really excited about a banana and start to associate the banana with that red light that goes on and develop cue-induced craving. So every time it sees a red light, it starts to think a banana's coming. And then might eat lots and lots of bananas, develop some tolerance for bananas. He might need 2 instead of just 1. And if he doesn't get bananas, he might be really mad at you. So it starts to develop withdrawal if he doesn't get access. And that is exactly coded in his this monkey's neurons, so that could lead to impairment. So there are biological signatures to each of those processes. And so if you look at this, this is literally dopaminergic signaling. Stage 1 is like that initial experimentation phase where you can see some salience and some reward coded through dopamine. And then in stage 2, a transition to addiction where you need to have more and more salience to have the same effect, and then a significant drop that's signaling withdrawal and tolerance patterns that are reducing the amount of reward that's experienced, but increasing the amount that's needed in order to reach sort of a baseline state. So as use increases over time, there's like that compulsive process that builds over time. What that looks like in the brain of humans is that there's a reduction, like I said, in the receptor density. And so this is showing folks who were administered methylphenidate, so like Adderall, basically, in their dopamine system in cocaine-addicted subjects. And so when people have a placebo, there's sort of nothing going on, but compared to that, there's way less dopamine receptor density when people are addicted to methylphenidate. And so you can see that people are feeling less high with more addiction and less receptor density, but have more craving, right? So that's what's happening in these two different pictures. And so rewards just don't do it in the same way as people develop more addiction syndrome. And what that looks like from a sort of behavioral perspective is shown in our substance use disorder diagnosis in DSM-5. And so it's broken into specific substances of abuse, but all of them include specific criteria, right? So it's a problematic pattern leading to clinically significant impairment or distress with 2 of these symptoms occurring in a 12-month period, right? So it's impaired control, risky use, social impairment, physical dependence, right? And so we've talked about how many of these processes could be part of that learning pattern, that reinforcement learning that has impacts on our brain. And the severity disorder indicators for these disorders are based on impairment or distress and the number of symptoms. And so a lot of it might be related to how learned a process has become through time. And again, we're looking at this because we have one brain and it's the same brain system for all different kinds of substances, whether or not they're drugs of abuse or not. And so I'll hand it off to Sarah to talk about some unique characteristics of what this looks like for folks with substance use disorders.
Thank you. Can you just advance to the next slide real quick, because I will just sort of jump right into it while you catch your breath. So there are definitely some distinct differences when it comes to substance use disorders versus eating disorders. Some of it are things that we have discussed in the past 2 weeks in each of our different talks, but I wanted to dive just a little bit more into some of the substance specifics here. So in terms of like looking at demographics, who is this affecting besides many people? We can see, so these statistics are taken from the U.S. National Survey on Drug Use and Health, the 2023 survey is where this is coming from. So we can see that 12 to 17-year-olds constitute 8.5%. So the majority of people who are using are fortunately people who are 18 and over, though we cannot discount that group of younger individuals. If we look at male versus female, males are accounting for a slightly larger percentage of the population of individuals. And then also breaking it down by race and ethnicity. And these are, I should mention, these are individuals who are diagnosed with a substance use disorder. So this is not just any use. These are people who, to Becca's point earlier, they have met the criteria of, 2 or more of those specific symptoms as defined by the DSM. So we can see American Indian and Alaskan Natives have a slightly higher percentage than the other groups, but it is broken down, as you can see, with individuals of Asian descent with 9.2% being the lowest. When we look at age of onset, we can see, and I did allude to this a little bit last week as well, inhalants have the lowest age of onset at 15.4 years. It could, and that's kind of the general. If we look at sort of the, the breakdown, there are individuals obviously who use at points earlier than this, but that's generally because of the ease of access where individuals will start. Age of onset is slightly higher for some of the other substances that do also have a little bit easier access: alcohol, marijuana, tobacco. You can see 16.4 years is the average age of onset for those. And then when we come to some of the harder substances, if you will, cocaine, heroin, stimulants, etc., it's just above 17 years old, and that it does vary by substance as well. And when you look, I did put a little infographic down there. So past year substance use disorder broken down by substance. You can see that there are 82.9% of people have no substance use disorder in the past year. So that's a good chunk of people who are not experiencing the severity of symptoms to be diagnosed. Among those who do have a past year substance use disorder, alcohol is the most common with, I think that says 28.9 million, followed closely by a drug use disorder, which can, that there's a lot of things that can go into that category. But as you break it down further, marijuana, a prescription pain reliever use disorder, methamphetamine, other prescription stimulants, cocaine, and heroin down at the bottom. So as Becca had talked about the tolerance and withdrawal, I think she covered a lot of the really important pieces. With substance use disorder, I think one of the important things to note, and it talks about this right underneath in physical effects, is that both the use of substances as well as discontinuation of substances can lead to some really significant complications: physical, behavioral, emotional, and that is one of the things that makes substance use disorder different. So we discussed tolerance and that higher salience, needing more of the substance in order to achieve that desired effect. This can occur with any substance, right? If you think about, for anybody on here who, like me, drinks caffeine in the morning, if we think about needing that cup of coffee or whatever it is that you have, in the morning to kind of kickstart your day, if you will, that is, in terms of tolerance, many of us have probably built up a little bit of a tolerance for the caffeine. And so thinking about, like, what do we need to get us to our baseline versus if we want to achieve a certain desired effect, how much more would we need? And over time, that amount increases as we continue with the use of the substance. Withdrawal is, the physiological response that's going to happen when the substance use is discontinued. And again, for substances, this can vary in terms of the impact. So from mild fatigue, some anxiety, irritability, things like that, all the way to the more extreme end: sweating, vomiting, delirium tremens, seizures, that can result in death. And so as we're looking at, again, some of the withdrawal and overdose risks, alcohol and benzodiazepines, which I did mention last week, the withdrawal from those are the particular ones of concern. Not that others are not, but in terms of what can be fatal. The discontinuation of these substances when taken in amounts that are going to very significantly impact, brain chemistry and things like that, can be fatal. Overdoses can occur with a number of different substances. It can occur with combination of substances or, individual substances on their own. And most often it's due to the impacts on respiration, heart rate, and sometimes in combination with other, like, medical conditions. So, individuals with heart conditions who are using amphetamines or stimulants or something like that. When we're looking at neurobiology, and again, Becca did a really good job of really starting to break some of this apart, we're talking, again, a lot about tolerance and withdrawal being mediated by the changes in the dopamine. So, excuse me. So, some of the brain changes, as she had mentioned, we're seeing that we have an increase in the incentive salience. We have a reduction of the brain systems that are involved in the experience of pleasure and reward. We have a heightened activation of the brain stress system. And we also have a reduction in the functioning of the executive control system. So the prefrontal cortex, all of that is just shutting down. So we're not really able to make decisions. We're not regulating our actions. We're not regulating our emotions. Impulses are sort of taking over. And then when we're looking at some of the changes in metabolism, every particular drug or substance of abuse has its own kind of unique toxicity profile. So amphetamines, they're known to affect the cardiovascular system and neurological systems. This can really exacerbate the risks for like metabolic syndrome, as an example. If we're looking at something like methamphetamine, cognitive deficits and abnormal metabolic activity can affect the nutritional status. There's actually a number of studies that are looking at the nutritional status among those with methamphetamine use in particular. And of course, if we, another example would be alcohol. Changes, liver injury, malnutrition. So that's going to lead to like a lot of vitamin and mineral deficiencies, which affect the cellular metabolism and epigenetic profile. Each drug of abuse, as I said, kind of affects that overall metabolism in a really complex way. And the changes can eventually contribute to cell damage, organ damage that's going to manifest in tissue damage, eventually kind of impacting like the aging and rate of disease and things like that. So, substance use. In comparison with eating disorders, when we look at substance use disorders, this is very heavily a system of under control. So it can be due to some genetic factors, impact of development of the substance use disorder, along with substance specific factors. So something like alcohol sensitivity, for example, the density of the receptors, as Becca was talking about. So what is under control? Essentially, we're looking at high levels of impulsivity and emotional expression, low levels of self-control and inhibition. Not the best combination. So temperament is going to be kind of one of those elements of it. So we look at a high activity level, a high distractibility level, and a low persistence or perseverance. So earlier, what we see in terms of the temperament is a lot of earlier like disengagement from family, gravitating towards peers who are of a more deviant, if you will, peer group, which leads to potentially an earlier onset of substance use and then more significant substance use later on. When we look at the personality component, we see high sensation seeking and poor impulse control, which have long been associated with risky behaviors, including substance use. The neurobiology, again, Becca did a really good job at kind of talking about this. So we do have like an increase in that reward-related dopamine. Oh my gosh, I can't even say the words anymore. We want to increase the reward seeking. And that happens oftentimes before the development of the prefrontal cortex. So in that time, especially those teenage years, and we have, not only do we have the prefrontal cortex not being fully formed, but we have this in combination with an already present difficulty with cognitive control. So in terms of the treatment approaches, and this is definitely different. We have the first line approaches truly are going to be like the pharmacotherapy. So we have things such as, methadone, Suboxone, extended release naltrexone, things like that. Whenever you're looking at the research and looking at first line approaches, medication for the substances for which it's available, which is generally going to be opiates, opiates and alcohol, though there are some clinical trials actually happening at Penn right now for cocaine as well. But pharmacotherapy is going to be really your first line treatment. CBT is one of the other clinical approaches, and really, what makes CBT a good approach for this is helping to assist people identify, avoid, and cope with situations in which they are likely to use, right? So you have that like trigger, thought, feeling, action. What can we do? Um, a lot of a lot of relapse prevention planning happens within the CBT framework. We have motivational interviewing and motivational enhancement therapy, which we're really looking to use strategies to kind of maximize a person's readiness to change their behaviors related to their use. So it's not necessarily about complete discontinuation. It's not even necessarily about behavior change in the moment. It's about increasing readiness for change talk. Contingency management. This is something that a lot of the research really looks at it in terms of use for stimulant use disorders and with adolescents as well. But this is using positive reinforcement for demonstrating desired behavior. So increasing in like rewards and privileges, things like that. They have, like gift cards, tokens, level systems, that kind of thing. DBT, another really important approach in terms of the substance use disorders. And here we're really looking to increase the skill use in order to manage emotions, reduce the impulsive behaviors, and improve the interpersonal relationships that often that are often found in individuals with substance use disorders. And then 12-step facilitation and other mutual support groups. So structured support that really emphasize personal accountability, mutual support, things like that. Again, there are a variety of different variations of 12-step groups. Not all of them focus specifically on spirituality. Not all of them focus specifically on abstinence as well. Second line treatments is really where we see a lot of the family therapy. So that is, again, something that is a bit different than specific approaches for eating disorders. And what often happens in terms of the family therapy is that family therapy is definitely emphasized within addictions treatment. However, it often occurs in parallel. So you have the individual with, the substance use disorder, the substance use issue that's receiving treatment. And then separately, you have the family members, whether it be parents, spouses, children, et cetera, who are kind of receiving their own support and their own therapy, learning how to manage what they've experienced, as opposed to having all of the individuals working together on ways that they kind of as the unit can heal and can move forward. So role of abstinence and harm reduction in treatment. I appreciate that this is in here. I first want to state that like abstinence is a part of harm reduction. So I know that I have put the good word out there as much as humanly possible. But for the majority of the majority of the field, I think when people are thinking about substance use treatment, the abstinence only approach is what has dominated the field for a very long time. Fortunately, like 70s and 80s, the harm reduction movement began and has grown throughout, and I think has gained a lot of really significant strides, especially since I would say probably like 2013 or so, when wave 3 of the opioid epidemic really started. And I think when we were really seeing the increase in overdose related deaths rise, and recognizing that perhaps we need an approach that's going to encompass individuals, even those who are not necessarily ready to discontinue their use. So really looking at trying to join with individuals, meeting them where they're at, and being able to give treatment that's going to look at supporting that person right now where they're at, and as best as possible reducing the adverse outcomes that they're experiencing as related to their substance use. So it's not like the only way to go is going to be completely discontinuing use of all substances. There is a path to recovery that does look different than that traditional approach, and that incorporates, that includes individuals who may not be ready for that complete discontinuation.
Great, thank you. So I'm going to, we've talked about, the neurobiology underlying substance use disorders and how they develop, and also some of the unique components of that syndrome and its treatment. So now I'm going to talk a bit about similarities between food and drugs, and then unique things about eating disorders that are different than substance use disorders. I'm going to run us through this quickly, but just take a look at all these delicious foods. Maybe you're drawn to the chocolate dripping down the side or that gooey grilled cheese. Right, so just take a moment to notice that, and all of a sudden we've experienced some addiction symptoms together. So if we imagine like a never have I ever game, we've probably all craved chocolate or pizza or some other food, wanted to eat more, learned eating more than anticipated, felt a loss of control, spent a lot of time acquiring or recovering from food or avoiding things because of food. Right. And so if we think about if we just looked at addiction criteria and applied it to food, it would only be natural that we'd say yes to a lot of those things. And that's because our brains have just one reward system that can be activated by food or by drugs. And it's pretty evolutionarily salient, right? So this mesocortical limbic system was made for food, and drugs hijack this system. It's not the other way around. And with food, we have both internal and external cues that activate our homeostatic system that wants to create balance and make sure that we have adequate nutrition at all times. And really high caloric foods are better for survival. So it's only natural that we would want those foods and get as much as we could of them in order to maintain our survival. The systems themselves are pretty complicated, right? So drugs operate really just on the brain in that mesocortical limbic reward system, but food also operates through peripheral systems in our energy systems, and get feedback from the body, right? And that can increase or decrease the reward value of things in real time, right? So for example, if you've ever been really hungry, probably that sandwich that you have all the time tasted way better when you're hungry. That's because of our homeostatic processes increasing the reward value in real time. And so that's naturally what our systems are supposed to do. And drugs sort of hyper like utilize that same system in a different way. So brings us to the question of, is food like a drug? And I would actually really say like, is drug like a food? But we would think about, is it rewarding? Is it reinforcing? Or does it involve the mesocortical limbic system and dopamine? And I think it's pretty obvious that food is a primary reward. It feels really good. Sometimes we can feel high on foods. I'm going to skip this video, even though it's really cute, and instead show you rats getting super excited about food. So it's learning how to push the button for that pellet, right? So not only will rats work really hard for a zap to their dopamine system, but they'll work really hard for gross food. People and animals have cue reactivity, right? So that animal was seeing the light and knowing the food was coming. People have cue reactivity both for drugs and for food. So if you see these images, your brain is responding to them in the same way that that animal is responding to the flashing light. When we look at cue reactivity for food and for drugs, there are overlaps in common exactly in that mesocortical limbic system, right? And so, yes, they're operating on the exact same parts of the brain. However, the magnitude is really different. And so there is dopamine released for food and for drugs, but the magnitude is different. So this is cocaine in the accumbens, and this is food in the accumbens. So the magnitude of the change, if you look at the scale, is really different. And so drugs are just turning up the volume on a natural response that food has. So we have talked about, right? Food is rewarding, it's reinforcing, it does involve that dopamine system. Food cues activate the ventral striatum, and you release dopamine in the ventral striatum. There are some other ways too, right? So people get food cravings. We feel bad when we stop consuming food, and that again is really natural. It's very common when people diet or restrict their food intake. Sometimes people get sugar crashes or get hangry. That's something that I experience quite often. And those are our homeostatic mechanisms at work, right? That's a natural process. That's not an addictive process. It's something that is maintaining our survival. People report feeling that food's like a drug. Like they'll say that they're chocoholics or sugar addicts or overeaters. But again, I think that might be a misinterpretation, that this system is really just made for food. And so that's our body telling us that we're hungry or we need more nutrition, more than something that's maladaptive or pathological. which brings us to the question of like, can we actually be addicted to food? And this is a hot topic in eating disorders land. It's something that researchers like to talk a lot about and have big opinions about. But we can look at animal models, right, and think about whether that happens for them in a way, because we can manipulate what they get to eat. And so if we give rats Oreos, we can see what happens. There are two animal models for trying to create food addiction. So one is intermittent exposure to hyperpalatable foods like sugar or Oreos. And so basically they put rats on diets. So they reduce their exposure to food in general and then give them access to high calorie foods, sort of replicating like a yo-yo dieting like phenomenon. And what happens is that after rats are deprived, they eat more, they binge eat, they prefer sugar to cocaine, they get withdrawal-like symptoms. And this is their percent consumption under conditions of deprivation or not deprivation. And again, this is like a natural process that if you're deprived, you would naturally want to recompensate to be able to maintain homeostatic mechanisms. There's another model where they get a cafeteria-style diet. This is the cafeteria at Yale that I used to see students in. And when we give rats access to pellets or to, like as many as they want, they get bigger. If we give them access to Oreos and other things too in their cafeteria-style diet, they also get bigger. But they don't get that much bigger. So if they have normal chow, they get a little bigger, more variety gets exciting, so they get a little bit bigger too. And their brains change a little bit. So they have fewer D2 receptors when they have the cafeteria style diet, which is part of the body showing like receptor downregulation, which is impacted by diet type 2. So that's again that natural homeostatic process. And if we think about why that might be the case, it's adaptation to prevent starvation. So, of course, if you're in the presence of regular access to rewards, it would encourage you to take advantage of it. It's a natural system responding to changes in the environment. There are some parallels with humans, right? So people who fast often report feeling super hungry later. There's also parallels in the relationships between food restriction and binge eating. Like when I talked about the Minnesota starvation experiment a couple weeks, that when bodies are not getting adequate nutrition, they naturally increase the reward value of food so that you have more of it. So, which brings us to the controversial question of, can people be addicted to food? Some people think that there's overlap, especially with binge eating disorder. I personally don't think so, because we need food to survive. We don't need drugs to survive. And this is a natural system to prevent starvation and maintain survival. And there's really good data that believing in food addiction is correlated with eating disorder symptoms. So that loss of control feeling, which might be more of a cognitive artifact of other beliefs about foods being bad. And there are really similarities and differences in the syndromes. So I will talk about those similarities and differences now. So in terms of demographics for eating disorders, the onset can be younger than substance use disorders, so even as young as 5, and onset can happen across the lifespan. They were really historically diagnosed in skinny white affluent girls, which is the slag stereotype, but we now know that eating disorders happen with people of all sizes, races, socioeconomic statuses, and genders. There are some psychological vulnerability factors, including some, personality traits like harm avoidance, perfectionism, and there are some disorder-specific differences. And so it seems like for folks with anorexia, there might be more sensitivity to punishment compared to folks with bulimia and binge eating disorder, which may have more sensitivity to reward. People with anorexia seem to have less cue reactivity to food, whereas folks with binge eating disorder and bulimia tend to have more cue reactivity to food, which might be more related to learning, right? That if you learn that something is rewarding, you have more cue reactivity. And people with anorexia don't eat rewarding foods that often. And then there's some personality or control related pieces to parallels to that too. People with anorexia are less likely to have comorbid substance use disorders, but people with bulimia are more likely to have comorbid substance use disorders. And so that's, again, that parallel learning process and the way that our mesocortical limbic dopamine systems adapt in terms of receptor density over time. So if we look at reward systems, for cue reactivity, again, there's reduced activation in anorexia. It might be increased in bulimia and binge eating disorder, but there's differences in the data when it's food specific or like general rewards like money. In terms of receptor density, there's some data of decreased D2 receptor availability in anorexia, increased receptor availability in anorexia and reduced in a larger body. But there aren't studies in bulimia and binge eating disorder about receptor density. So that again is, likely more related to frequency of rewarding substance consumption than anything else. There might be more of a balance that shifts between reward and control in eating disorders. And so if we look at cognitive control and decision making, that could vary across different eating disorders. For example, one way to measure that is a delay discounting task, which I'll explain in just a moment. I'll show this here. So the task is like, do you want $100 now or $101 in 31 days? Right. And it sort of increases the amount that you would get if you delay. And the more that someone delays, the sort of better control they have over immediate rewards. Having more delay can be an interaction between reward and control. It can mean that $100 means a lot or means not a lot to someone, or it can mean that they're really patiently waiting for a bigger reward. And what that looks like in eating disorders is that folks with anorexia are really good at delaying. Which is related to striatal changes, so changes in their dopamine system. So before and after treatment, people have more striatal reactivity when they have anorexia, and so they're less good at delaying later on. And so this might not be related to control, it might be more about increasing reward overall. Another way to look at control is thinking about how do I override an automatic response, like the Stroop test, where you like read the colors and the words differently. And so for people with eating disorders, it seems like the data are mixed in meta-analyses, but in general, people seem to have like a tough time doing that, probably because they're malnourished a lot of the time. But it's harder for them to do that with disease-specific stimuli. So when it's like body-related or food-related, it's much harder. So there might be some control problems there. And then another example of this is set shifting. So how fast do I adapt to changing rules? So this is like a Wisconsin card sorting task where the rules change to how you have to sort them through time. And if you look at that across eating disorders, it seems like in general, there's like a deficit in that process in meta-analyses across studies. And so it looks like there's difficulties with both reward and with control. The control pieces are present across disorders, and the reward processes seem to differ across conditions and perhaps other variables. What this seems to be suggesting to me in the context of eating disorder literature is something that may actually be more of a parallel than a difference with substance use disorders. And so like we talked about from the very beginning, there's a learning process that goes from sort of impulsive reward motivated activity to compulsive actions to avoid withdrawal. And what that looks like in the brain is it starts out with like, I want the reward, and then it's difficult to stop, and then it's hard to be flexible, and then behaviors and actions become compulsive. And that's something that would be true in any sort of reward context, would certainly be true for food and for drugs. And this balance between impulsivity and compulsivity might be more indicative of disease state and learned processes than something very specific to a condition. I will say, though, the data for substance use disorders is really well articulated, right? That you can see across illness stage the relationship between these different processes and how sick patients are. For eating disorders, the data is still very preliminary for a few reasons. One is that there's a major confound with nutritional status. So, for example, when you're hungry versus when you're full, your reward reactivity and your cognitive control are very different. It's confounded with body size, which is something that, is just unfortunate, right? That it's hard to know exactly what is related to like psychopathology compared to, nutritional status and body size. And there's confound with illness severity, right? So that learned process, like where are you in that learned process in terms of like how severe the illness is? And then patterns that look different with food reward don't always generalize to non-food rewards or general cognitive control. So there's sometimes a stereotype in eating disorders that like anorexia is a disorder of more control, and binge eating disorder or bulimia are disorders of less control. But what the data seem to really point out is that that is specific to the context of food for the most part. And plenty of people with bulimia and binge eating disorder are also engaging in very restrictive, controlled eating a lot of the time. It's just not a match for their homeostatic processes, right, which are really trying to keep them safe. And they also tend to perform very well on measures of other kinds of cognitive controls that have nothing to do with food. So it's, I think part of a stereotype in eating disorders that doesn't really reflect the data. So we've talked about neurobiology, substance use disorders, overlaps with food and drugs, and then perhaps some eating disorder specific population components. In trying to make a Venn diagram model for these disorders, it's pretty tough to do that. So I made a list and tried to think about it in a couple of different ways. When we compare eating disorders and substance use disorders, there are some really profound similarities. Right, so there's definitely for many people this experience of loss of control, and we know that loss of control, that itself, that experience, is correlated with psychopathology. There is continued use of substances or food in folks that are binge eating despite consequences. People can have a hard time cutting down or shifting their behavior. There's cravings or hunger in the case of eating disorders. Impulsivity is sort of a common risk factor. There's also possibilities of compulsivity and reduced cognitive control. There can be comorbidity between the disorders as well, although less so in anorexia. That being said, there are also many differences, right? So in eating disorders, shape and weight concern is a major component of our conceptualization, and it's unique. It's not something that's part of substance use disorders. The idea of fear foods is also kind of unique. Like people with substance use disorders might have fear surrounding the consequences of relapse or other kinds of fears related to it, but aren't fearful of the substance themselves, I guess. So that's something that's a little different. Time consuming substances is important for binge eating categorization, but not for substance use disorders. Withdrawal is a criterion for substance use disorders, but not eating disorders. I would just, again, consider that to be hunger. Tolerance is a criterion for substance use disorders, not eating disorders. Type of substance is important for substance use disorders, but food type doesn't matter. There are some abstinence-based treatments for substance use disorders that Sarah so gracefully articulated, and all the nuances surrounding that, but we are certainly not able to abstain from food, and so that is not something that is an option for eating disorders. And, binge behavior is in some ways a natural response to restriction in eating disorders. It's not really in response to tolerance or withdrawal, and compensatory behaviors seem to be unique to eating disorders. So looking at this list and trying to find, how other folks have conceptualized this, really what I came across is two different ways to think about this. One is in that context of learned behavior, that shift from impulsivity, so like reward-driven behaviors, to withdrawal-driven behaviors, from impulsivity to compulsivity. And so if we look at all, or like a big picture perspective of a Venn diagram between impulsivity and compulsivity, there are some disorders that are really characterized by only impulsivity, like ADHD or mania, and some that are characterized by only compulsivity, like OCD. But really, substance use disorders and eating disorders seem to be driven by both, right? That's a similarity. That learning process is part of both of them, and something that is a nuanced piece of both of those conditions. Another example of a Venn diagram that's going to look sloppy is this one about, impulse control disorders, and a gambling disorder, for example, is our only behavioral addiction. And if we sort of imagine here, this is sort of where like a behavioral addiction would be, or like a food addiction would be if that existed. But really, And like if addictions are right here, I would say that eating disorders kind of span everything, right? It's like a really bad model in that way because there are folks that have all of these comorbidities within eating disorders. And so it gets really sloppy and messy, which really begs the question of whether graphically representing them this way like really makes sense, and suggests that really thinking about dimensional aspects of categorization across disorders might be the key, right? That really what we're talking about here is dimensions of reward and cognitive control rather than how categories overlap. And so if we think about the value of this dimensional approach, right, we're talking about overlapping reward systems. We have one brain that can uses the same system that can be hijacked by a drug. These control processes might be overlapping. And there's that learning role and that shift from impulsivity to compulsivity that likely depends on illness stage and comorbidity. And so I think the hopefulness of a learning-based conceptualization is that it suggests opportunity for treatment. If these behaviors are learned, they can probably be unlearned, right? Perhaps with some pharmacological support as part of that. And it would only be natural through learning to have not ambivalence for new behavioral patterns, which is, the great target for motivational interventions. And it would be only natural to need distress tolerance to navigate symptoms of withdrawal or anxiety during change. Only natural to need to have exposure to increase the value of good rewards, of like food, of enjoyable activities, of spending time with people to reactivate that dopaminergic system in a more adaptive way. And that it's not about white knuckling it, right? Like control is not enough to change reward patterns. And so you'd need repeated learning. I'd also suggest some ways to minimize craving and reduce risk for relapse, like the real substantial importance of medication therapies for substance use disorders, right? To reset that biological disadvantage folks are at when they have tolerance and withdrawal. Likewise, for eating disorders, regular eating serves that purpose, right? Of like calming our homeostatic processes and resetting our baseline so that folks aren't thrown in behavioral extremes because of, body needs and that reward system. And the importance, right, of behavioral activation for both conditions, that if reward is something that is dysfunctional, having regular behavioral activation patterns that relearn reward patterns could be really important for sustained recovery. And so that is what we prepared. I will see what questions we have. And thank you all for joining.
Nothing in the chat so far.
Oh my goodness, we stunned you with neuroscience. Well, I will say that our AIDS code again is 61 TUNS, like Tom's, but with an N. And if anyone has any questions, feel free to pop them in the chat or say hi. Oh, it's the last slide again, please. Let me see if I can do that. Dr. Murray's asking about the role of negative reinforcement in the disorders. Sarah, do you want to take this or do you want me to?
Go ahead. I was going to alert you to the fact that there was a question.
Okay. Well, Dr. Murray, I'm sure this is something that you know quite a bit about. But I would say that, if we think about reward and reinforcement, right, that the positive reward value of something early in an illness, like for a substance or for a food item, or for the social reinforcement of positive feedback around like bodily changes or restriction, right? Like starts out as something that folks can be driven by. And then as people develop tolerance for those rewards or have other kinds of changes, it would then shift, right, to sorry, I'm seeing another question, so I'm getting overwhelmed. It would then shift, right, to that they would lose their value through time, and it would need to get more and more extreme to reach that same level of reinforcement. Negative reinforcement in in the context of this question, I think, is saying that it takes away something that would have been, it feels good to have something taken away, right? So another kind of benefit. So I think that this is the uh, sort of like if someone feels really badly and having a drug takes away that bad feeling, right? That's reinforcing too. And so I think that is a whole different, like domain of how these kinds of processes can occur, but absolutely is part of it. And think that for both eating disorders and substance use disorders, there's a major role of drug taking or restriction or food taking, right? That would then alleviate other forms of distress and take away something that was uncomfortable. So that is a similarity.
Yeah, I was going to say too, and it does so on a level that is so much higher than we could, for substances anyway, that we could ever naturally replicate. Which again, I think just increases the reinforcing aspect of it.
Yeah, that's great. And then Amanda's asking a question about behavioral activation. So behavioral activation is a treatment that was originally developed for depression, with the idea that in depression, people just don't find things as rewarding as they used to. And so by planning to engage in enjoyable, rewarding activities and testing whether they actually are more rewarding than you anticipate, it then changes and relearns the process of enjoying things through time. And so I think that is also a dopaminergically mediated process. And the data on that are actually really elegant, that when people engage in behavioral activation, they have shifts in their dopamine system that correlates with symptom reduction for depression. I think that behavioral activation outside getting access to that reward outside of the domain of food and drugs, or restriction and drugs, or eating disorder behaviors and drugs, is an example of like rewiring that dopaminergic system so that folks are driven towards more balanced behaviors through time, and shift away from relying only on that single form of reward they get from their disorder.
And I think, sorry, just to tack on to the end of that, if we're thinking like, it reminds me a lot in terms of like DBT language for any of the women's therapists on here, like mindfulness of pleasant events, right? But another thing that I think is important in terms of the behavioral activation, specifically for substance use, is being able to set people up with like appropriate expectations that engaging in behavioral activation and doing these things is not necessarily going to give them exactly what they are looking for, in the same way that the use of the substance does. But again, over time, being able to start to kind of rewire and find that balance again.
All right, any other questions? All right, well, thank you everyone for joining us today. We really appreciate it and hope it was a helpful presentation, and we'll look forward to seeing you next time.